Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. I am Dr. Mudassir Shabazz, Associate Professor of Anatomy, Sahara Medical College. So in the previous lectures we have discussed about the osteology of the thoracic chest, osteology of the thoracic wall, that is ribs, vertebrae and sternum, and today we are going to discuss something about the superior inferior thoracic apertures and also the joints of mainly the joints of the thoracic cage. So if we see this slide, here is shown the superior thoracic aperture, means that aperture through which the thorax is attached to the neck and structures from the thorax comes out, that is the vessels, and passes to the head and upper limb, and certain structures from the neck region, they enter through this aperture into the thorax, that are the trachea, esophagus, along with the nerves, sympathetic part, that enter into the thorax. That's why it's called as superior thoracic aperture. Two names have been given to this thoracic aperture: thoracic outlet and thoracic inlet. Thoracic outlet because the great vessel, that is the artery to the head region, head and neck region, and artery to the limb, upper limb, that comes out from the arch of aorta into the neck region and then to the upper limb and head region. And the clinicals regarding these great vessels are very important, and the clinical symptoms produced by compression of these vessels are very important. That's why it is named as thoracic outlet. And the disease produced by this is thoracic outlet syndrome. But it is also called as thoracic inlet. Why? Because the great veins, they tend to enter into the thorax, and also the viscera, that the esophagus and trachea, that are very important viscera, they also enter into the thorax through this aperture. That's why this is also called as thoracic inlet. So the both terms are used for this superior thoracic aperture. Is completely surrounded by the skeletal element. That means anteriorly you see here is the sternum, manubrium sterni, and here is the first rib attached to the sternum. Then this first rib is attached to the first thoracic vertebra. So posteriorly is the T1, on both sides the first rib, and anteriorly is the sternum. So it is completely surrounded by the skeletal element. So here is a cut section of the superior thoracic aperture. Here is, you can see the name given is the thoracic inlet, superior thoracic aperture. Why? Because esophagus, trachea and veins and the nerves, that is the vagus nerve and phrenic nerve, they enter into the thorax from the neck. That's why it is given the name of the thoracic inlet. But the great vessels, brachiocephalic artery on the right side, and on the left side, the left common carotid and left subclavian artery, they are coming out of the thorax to the head region and the upper limb. So in this cross section, we are seeing this cross section from below, That's why it becomes the right side and this becomes the left side. Now, if we see, we can see the certain structures and understand the relations of the structures at the thoracic inlet. So on the both sides are the lung apex. This lung apex will be covered by the pleura, parietal pleura, and here that is named as the suprapleural membrane. Now, in the if you go posteriorly, posteromedial to the lung apex, here is the sympathetic trunk, then is the supreme intercostal vein, then is the superior intercostal artery, and then is the first thoracic nerve. So these structures are arranged in this manner at the apex of the posteromedial aspect of the apex of the lung. Posteromedial. This is the first thoracic vertebra. Posteriorly on the both sides are the prevertebral muscles. If we move into the center, anterior to the body and the prevertebral fascia, prevertebral muscle is the esophagus. And anterior to esophagus is the trachea. You can see here on both sides of the, between the trachea and esophagus, laterally on the lateral edges is a nerve which is coming from the thorax region, coming back towards the neck region, is the recurrent laryngeal nerve. So here is the location of recurrent laryngeal nerve. On the left side, if you see this green structure, this is the thoracic duct. If we move more anteriorly, lateral to trachea and between the anteromedial part of the apex of the lung, there are certain structures present. That is the left subclavian artery here, then is the vagus nerve, then is the phrenic nerve, then here is the very important structure, that is the brachiocephalic vein that crosses to the right side to join the right brachiocephalic vein. And medial to this, you can say posteromedial to it, is a vessel that is left common carotid, which is very important blood supply to the head region, to the brain. If we move anteriorly, we see in the center is a vein that is the inferior thyroid veins. Because the thyroid is present in the neck region, they drain into the directly into the brachiocephalic vein. And here, if we move anteriorly, anterolateral part, here is the artery. You are saying that having origin from the subclavian artery, internal thoracic artery. If we move in the center, in the median plane, here we see thymus, which is a part of the superior mediastinum. Anterior to it are the short muscles of the neck region that you will study in the head and neck region, that is the sternothyroid, sternohyoid muscles. These are the short muscles of the neck. And most anterior is the manubrium sterni. And on the right side, same nerves are present, vagus nerve, phrenic nerve with the brachiocephalic vein, and here is the brachiocephalic artery. So on the right side, it's not the subclavian and carotid artery. They will originate, they will continue branches of the brachiocephalic artery. On the left side, there is no brachiocephalic artery. They have direct origin from the arch of aorta. But on the right side, the brachiocephalic artery is directly originating from the arch of aorta, but then it will divide into these two arteries, common carotid and subclavian. Anterior to this brachiocephalic vein is the internal thoracic artery. In my opinion, because this diagram is very important from the examination point of view also, that very often question is asked the structures present at the thoracic inlet or superior thoracic aperture. So you can easily recall the structure present, and if you draw it yourself and then label it, then you can very easily understand the structure at the thoracic inlet. I think so from the examination point of view, the student should try to draw it and label it uh, many times so that it should be remembered by them permanently. Another diagram showing the thoracic inlet. The doma pleura covered by the suprapleural membrane, here you have seen in the previous slide, and this here is the thickening of the fascia, that is the Simpson fascia, that is the endothoracic fascia which is covering this membrane, suprapleural, you can say parietal pleura at the apex of the lung, that will be the form the suprapleural membrane, Simpson's fascia. And is there are muscles from the neck, the scalenus minimus and transfer process of C7. It extends 4 centimeters above the middle of the medial third of the clavicle. So if here will be the clavicle present, this suprapleural membrane will extend upwards up to 4 centimeters, but not above the neck of the first rib. Not above the neck of the first rib. So it is above the you can say the clavicle, but not above the neck of the first rib. So here are shown the different relations. You can define the relations yourself if you see the previous diagram. So posteriorly is the sympathetic trunk, superior intercostal vein, superior intercostal artery, T1 nerve first, rib, thoracic duct on the left side, anteriorly brachiocephalic artery, subclavian artery and vein, superiorly costocervical trunk, thoracic duct on the left side, and here is the mnemonic that the vagus nerve and phrenic nerves enter the chest between the arteries behind and veins in front. So if you uh, compare the statement with this diagram, you will easily understand the statement where or how the relations have been shown. This should be practiced by the student also. Inferior thoracic aperture means that should be present at the inferior side of the thoracic cavity, and inferiorly we know that is the diaphragm. So it's the diaphragm which is present between the abdomen and the thorax. So inferior thoracic aperture is completely closed by the diaphragm, but diaphragm itself may be pierced by the structure which are going down from the thorax to the abdominal region, that is thoracic aorta entering into the abdomen, but the certain structures they are coming above from the abdomen into the thorax, that is the inferior vena cava, thoracic duct, esophagus vein, they are coming, they are starting at the junction of the abdomen and thorax, but the inferior vena cava is coming down. Certain structures they also go out of this. So that we will study when we will study the diagram, the structure piercing the diaphragm and the levels at which they pierces the diaphragm, and they are connected with the esophagus. Also will pass from the thorax region to the abdomen to join the stomach, so there will be aperture for that. We will see that. So inferior thoracic aperture is actually is not aperture, it is closed by the diaphragm, which is separating abdomen from the thorax, and certain structure they will pierce the diaphragm either to enter from the thorax to the abdomen or from the abdomen to the thorax area. And this is a common sense that you can esophagus has to come out of the thorax to the abdomen, but inferior vena cava has to come from the abdomen into the thorax by piercing the diaphragm. So inferior thoracic aperture have here shown that the diaphragm is a balloon shape, that is its apex is upward into the thorax covered by the rib cages. So here you see if the height of the dome is present at the level of, if we count the ribs, first, second, third, fourth and fifth, up to the fifth intercostal rib, a fifth rib are touching the 1, 2, 3 and fourth intercostal space. You can see here the diaphragm, as the diaphragm contracts, height of the dome decreases and volume of the thorax will increase from above downward. Vertical diameter will be increased by the contraction of diaphragm. Here you can see the esophagus and inferior vena cava, they are penetrating the diaphragm and entering inferior vena cava, entering into the thorax, and esophagus is coming out of the thorax into the abdomen, and aorta has been shown here coming out of the thorax into the abdomen. Then here up to here will be the thoracic part of descending thoracic aorta, and below that it will be abdominal part. So if you see in this slide, the bone cartilage ligament at the margin, this is the costal margin. The inferior thoracic aperture is closed by the diaphragm. The structures passing between the abdomen and thorax pierces and passes posterior to the diaphragm. Skeletal elements, that the body of the 12th vertebra here will be the posteriorly rib 12 with it, that is a floating rib, and it will be 12, and 11th rib will be posterolaterally. Xiphoid process will be anteriorly, and the joint between costal margin and sternum lies roughly at the same horizontal plane. Okay, one thing that you have seen that in this slide, that the superior thoracic aperture is not straight one. This aperture is actually running downward and anteriorly from the first thoracic vertebra. So the level of the manubrium sterni, the suprasternal notch, is actually at the second thoracic vertebra because it is running downwards and anteriorly. So the posteriorly is a T1 vertebra, but anteriorly is the aperture level is the suprasternal notch is the T2 vertebra, and sternal angle level is the T4 disc between the T4 and T5 vertebra. But if you see diaphragm, it is running from T12, that is 12th thoracic vertebra and the rib, upward and anteriorly up to the Xiphi sternal joint. So that's the main difference you can observe. So it's not the straight, these apertures are not straight, but they are oblique one. Now we come with the articulation of the rib cage. So we see different joints. Anteriorly we see the joint between the manubrium and sternum, manubrium-sternal joint, then joint with the xiphoid process and body of the sternum, that the xiphisternal joint. Then the ribs, they will articulate with the vertebra of the ribs, they will articulate with the costal cartilages. Then the rib costal cartilages, they are making joint with the lateral border of the sternum, and also there are the joints between the costal cartilages also. So these are the joints. So if we divide them, there are the joints of the chest wall. Manubriosternal joint, it's a cartilaginous joint. Small angular movement possible there. Ziphisternal joint, cartilaginous joint, fuses at the middle edge. Joints of head of rib, first rib and three lower ribs have single synovial joint with their corresponding vertebral body. Second to ninth rib are synovial joints with the corresponding vertebral body and that of the vertebra above it. We have seen in the previous lectures that the same is the reason. Joint of the tubercle of the rib with a synovial joint with the transverse process of the corresponding vertebra. Joint of the rib and costal cartilage, these are the joints are cartilaginous joints, no movement possible. But the joint of costal cartilage with the sternum, they are first, only the first is a cartilaginous joint, the first rib and the sternum is a cartilaginous, primary cartilaginous, no movement is there. But second to seventh ribs, the costal cartilages that make the joint with the sternum, these are the synovial joints. So here is a brief one, the joints and the type of the joint that is present between the bones have been shown in this diagram. This whole table is given in the KLM, and here is the first one is the joint, then is a type of joint, then the articulation, then is the ligament, and then is the movements at that joint which are occurring. You can see, you can look in the KLM, and students very often they are very fond of this table. So first of all we will see cartilaginous joint, that the joint between the rib and the sternum. No synovial cavity, hyaline or fibrocartilage will be present, little or no movement. Two types, synchondrosis and symphysis. Synchondrosis, band of hyaline cartilage unite the bone, and this is the first rib. Epiphyseal plate temporarily between the manubrium and the first rib, sternocostal joint. Here is the joint, which is cartilaginous joint. Synarthrosis, no movement. There's a mnemonic of the cartilaginous joint. Cartilages enter the sinks or swims. Sinks or swims. It's not a synovial joint. Okay, so here is the example of that the joint between the sternum, between the rib and the costal cartilage is synarthrosis. No movement is there. But there is also no movement at this joint, joint of the first rib with the manubrium, not the body, manubrium. Is also cartilage, primary cartilaginous joint, synchondrosis. So these are the cartilaginous joint. Primary cartilaginous joint is between the first rib and the manubrium sterni. And bones are united by a plate, a bar of hyaline cartilage, no movement, temporary and ossifies later. Example between epiphysis and diaphysis and the first rib and the sternum. This is a plain type of the joint. Secondary other example is the secondary cartilaginous joint between the body, manubrium and body of the sternum. So that we will see. Costovertebral joints. Now we see how the ribs, they make the joint with the vertebra. Then we will see ligaments. So first is we see the costovertebral joint. This is a typical costovertebral, is a synovial joint from second to throat, 9. second through 9 is the typical costovertebral joint. So here you see first one is not included, and the 10th, 11th and 12th, they are also not included in this. The typical one, they will be atypical. The reason is that they have single articular facet on the vertebra for the articulation. For a typical costovertebral joint, there will be head of the rib, two adjacent vertebral bodies, and interposed intervertebral disc. You see here that the head of the rib, two vertebral bodies, and intervening intervertebral disc. And the second to 9, they are typical because there are two articular facets on the rib. We have seen before the two articular facets on the head of the rib for this joint, the so-called demifacets. And these demifacets on the rib, they are separated by a ridge. The small oval and slightly convex demifacet of the ribs are called superior and inferior costovertebral facets. The adjacent thoracic vertebrae have facets corresponding to those of the rib. There, I have already discussed with you that the lower facet will be the facet for its own vertebra. The upper facet will be for the vertebra above. So if we say this is the second rib, this will be the second vertebra, and this will be the first thoracic vertebra. Or if you say this is the sixth rib, so this will be the sixth thoracic vertebra, and this will be thoracic vertebra fifth one. Okay, so in this way they make the joint, and then these joints are supported by the ligaments. They are synovial joints. There will be a thin fibrous capsule, which will be surrounding the articular surfaces, articular margins. Three major ligaments support these joints, and these are lateral costotransverse ligament, costotransverse ligament, superior costotransverse ligament. So these are the three ligaments, major ligaments, which support the costovertebral joint. So lateral one is it is located between the lateral portion of the costal tubercle and the tip of the corresponding transverse process, okay, of the vertebra, between the tubercle and vertebra. Costotransverse, short fibers, and within the costotransverse foramina between the neck of the rib and posteriorly and the transfer process of the same level. So here will be the neck of the rib with the transfer process. Here also superior one is between the crest of the neck of the rib to the inferior border of the cranial transverse process. Cranial, upper one. So here we see. Here is shown the ligaments, you can name them also. So in this diagram, the names have been shown. Here is the costotransverse ligament shown at the neck of the rib, and is also called radiate ligament. Then is the lateral costotransverse ligament. Then is the superior costotransverse ligament. Intertransverse ligament are also shown here, but these are more concerned with the vertebrae. The crest of the rib is also attached to the intervertebral body through ligament. So superior, here is shown the facets, and here is the radiate ligament, then the costotransverse ligament, then is the lateral costotransverse ligament, then is the superior costotransverse ligament. So here again in this slide, the ligaments have been shown more clearly, so you can see the lateral costotransverse ligament from the lateral side of the transverse process. Then here is shown the superior costotransverse ligament between the uh, neck superior part of the and the cranial vertebra, with the cranial vertebra above. If you focus a little bit, you see this is the, if this is the sixth rib, this will be the sixth vertebra, and this will be the fifth vertebra. The fibers, they are running from the neck of the rib to the transverse process above cranial one. So this is superior costotransverse ligaments, and here is shown the lateral costotransverse ligament. This ligament, the costotransverse ligament or radiate ligament, here you can see the attachment of the fiber. Here are the fibers which are attaching with the disc. So these are the costal facets for the articulation of the tubercle of the rib, and these are the facets for the articulation of the head of the rib. Again, in this has been shown the, here is the intra-articular ligament for the head of the rib, that is from the crest to the intervertebral disc, has been shown. And here the other ligaments shown here: radiate ligament, superior costotransverse ligament, lateral costotransverse ligament. Now we will discuss, in the next lecture we will discuss the other joints of the thoracic cage, that is the sternoclavicular joint, sternocmanubrium and xiphisternal joints, then the joints of the ribs and the costocardiac with the sternum. In the next lecture we will study and movement. To understand the movement at the joint, we have to understand this axis of the movement that we will discuss it. Then we will be able to understand the movement of the respiratory movement of the ribs. So inshallah we will discuss in the next lecture.